Hey guys, welcome back to my channel, The ENT Resident. Today we'll be doing a case presentation on a very important topic, and that is atocoantral CSOM, or also known as the squamous type of chronic otitis media. I'll be giving you the history and the clinical findings of the patient, and then I'll discuss each one of those points, how that is indicating towards this diagnosis, and then we'll form a provisional diagnosis and discuss the treatment of the patient. You can also now purchase my notes. I have added links in the description. Okay, so let's get started with the history. So, this is a case of a 40-year-old male living in Bangalore, Hindu by religion, software engineer by occupation, who came with the chief complaints of discharge from the right ear for 2 years and decreased hearing in the right ear for 1 year. Now, coming to history of present illness, the patient is apparently asymptomatic 2 years back when he started complaining of discharge from the right ear, which was insidious in onset, continuous, scanty in amount, purulent in nature, yellowish in color, foul smelling, occasionally bloodstained, and relieved by medication. He's also complaining of decreased hearing in the right ear since the last 1 year, which is insidious in onset, gradually progressive, not able to hear whispered sounds, not fluctuant, no change in hearing during discharge or absence of discharge, and able to understand speech. Coming to negative history, there is no history, although this is not a negative history is not a point that you write in your uh, practical copies, but this is a history that you have to take and you should include at the end of your history of present illness. So there is no history of ear pain, giddiness, ringing sensation in ear, fever, headache, nausea, vomiting, neck stiffness, double vision or blurring of vision, irritability, facial asymmetry, trauma, noise exposure and ototoxic drugs history, and no history of nose or throat complaints. Coming to past history, there is no history of similar complaints in the past, no history of diabetes, hypertension, TB, thyroid, exanthematous fever, bronchial asthma, no history of surgeries in the past, and no history of known drug allergy. There is no significant family history, personal history seems to be normal, and addiction said there is no addiction history as well. Now, coming to the history of present illness, let's start discussing each one of the points that I have just mentioned. So, first chief complaint over here is discharge from the right ear, where the patient mentioned that this started insidiously, it didn't happen suddenly. So, what does this indicate? So, this is basically describing the onset of the ear discharge. Now, whenever there is an insidious onset, it is more indicative towards CSOM. Whereas, if this had a sudden onset, it would have been more indicative of diseases like ASOM. Next point, it is the discharge is continuous in nature. Now, what does that mean? Now, how do you differentiate ear discharge based on its nature? So, it can either be continuous or it can be intermittent. Continuous in nature, especially in terms of CSOM, since we are discussing a CSOM case, it points more towards the aticoantral type of CSOM. Whereas intermittent nature of the ear discharge will point towards tubotympanic type of CSOM. Next is the discharge is scanty in amount. So that brings us to the question of how will you quantify discharge coming from the ear? So here we have to ask the patient how much of the discharge, how much discharge is coming while he or she is sleeping. We can differentiate into profuse, moderate, and scanty. Profuse ear discharge is when the discharge starts coming out of the ESC, which is the external auditory canal, and it wets up the pillow during sleep. That means there is profuse discharge. And profuse discharge is seen in tubotympanic type of CSOM. Next is the moderate quantity of discharge. This is when the discharge remains in the external auditory canal. And this is also seen in cases of tubotympanic CSOM. And the third quantification here is scanty amount of discharge. Scanty is when a tip of the swab stick is stained by the discharge only. And this is very specific feature of the aticoantral type of CSOM. Now, why do we see scanty amount of discharge in aticoantral type? This is because the attic is lined with low cuboidal epithelium with no goblet cells. That is the reason why there is a scanty discharge seen in aticoantral type. Whereas in case of tubotympanic type, the area which is involved has a lot of goblet cells that leads to the production of more discharge. Next point is the discharge is purulent in nature. So that will bring up the question, what are the different types of ear discharge and what would be some of the causes of these different types of ear discharge? So there are 6 different types of ear discharge: serous, serosanguinous, watery, mucoid, mucopurulent, and purulent. So serous is when it basically means it looks like serum. This is seen in cases of seborrheic otitis externa or eczematous otitis externa. Serosanguinous is when it means it is looking like serum and it is also a little blood tinged. This is also seen in cases of seborrheic otitis externa and otomycosis. Watery is when the discharge looks clear water like. This is a typical feature of CSF otorrhea. Fourth type is the mucoid type, which is white and acellular. In this case, we see that the mucus threads will be seen when you try to suction the discharge. So, whenever you see a mucoid discharge, it is always, without a doubt, coming from the middle ear because the middle ear is lined by goblet cells which secrete mucin. So, a mucoid discharge is always indicative of a pathology in the middle ear. And this is typically seen in tubotympanic type of chronic otitis media, ASOM, and otitis media with effusion. Fifth type is the mucopurulent discharge, where what you see is a combination of mucoid discharge and pus. This is usually whitish yellow in color. And this is seen in secondary infection in tubotympanic CSOM and tuberculous otitis media. And last of all, the type that we have seen in our current patient that we are discussing is a purulent type of discharge, which is basically pus cells, which has dead lymphocytes. And this is yellowish in color. This is a typical feature of CSOM of the atticoantral type, in furunculosis, mastoiditis, and malignant otitis externa. So these are the different types of ear discharge. Next part is that the discharge is yellowish in color. Now, what can be the different types of color that you can see in your discharge and what will this color indicate? So, it can be whitish. In that case, it indicates a mucoid type of discharge. It can be whitish yellow, which indicates a mucopurulent type. It can be yellowish in our case, which is the purulent type. And whenever we see a yellowish discharge, the most common organisms involved here are Staphylococcus and Streptococcus. Next, if we see a greenish discharge, that is very, very typical of a pseudomonal infection. If we see blackish spores, that points more towards Aspergillus niger infection. And if we see a brownish discharge, first of all, it can be a physiological thing. If we see wax in the external auditory canal, but if it is pathological, it can be a Aspergillus fumigatus and Aspergillus flavus infection. So this is information that you get from noting the color of the ear discharge. Next, the discharge is also seen to be foul smelling. Now, what will foul smelling discharge indicate and why will it happen? The foul smelling discharge, this term that is used over here, is getting a fishy odor from the ear discharge. This is a very, very typical feature of atticoantral type of CSOM. And why is this foul smell coming? There are two reasons to it. One is because of the infection with saprophytic bacteria and anaerobic bacteria. And second is as a result of bone erosion. Now, is atticoantral type of CSM the only case where you get foul smelling discharge? That's obviously not the case. There are various other causes like tubotympanic CSM if it gets infected with Escherichia coli and Proteus, which is kind of rare. If there is a foreign body in the external auditory canal, if there's a cholesteatoma involving the external auditory canal, in cases of keratosis obturans, and in very late stages of malignant otitis externa. So these are all the causes of foul smelling discharge coming from the ear. Next point is the discharge is occasionally blood stained. Now, if somebody comes to you with a bloody discharge coming from the ear, first you have to divide them into two types. Is it a frank blood in discharge or is it just blood stained? Because both of them will have a range of different causes to it. If you see frank blood in the discharge, this is more indicative of trauma, polyp, glomus tumor, foreign body, otitis externa hemorrhagica, any malignancies, and granular meningitis. Whereas if you see a blood stain discharge, this is more commonly seen in aticoantral type of CSOM, again in case of an oral polyp, malignancy, and granulation tissue. So this is what we are seeing over here, a blood stain discharge rather than frank blood in discharge. So, what would be the causes of this blood stain discharge in a case of aticoantral CSOM? First of all is the presence of cholesteatoma. So, cholesteatoma is very notorious for causing bone erosion, and it also ends up damaging soft tissue and mucosa, leading to a lot of bleeding. So, the blood now starts to mix with the infected pus and it starts giving it a blood-stained appearance. Second reason is the presence of granulation tissue, and a third reason would be oral polyp formation. Now, oral polyps are very highly vascular, and any minor manipulation or infection of these polyps can cause them to bleed, and that will lead to the formation of blood stain discharge. So, these are the three reasons why you see blood stain discharge in aticoantral CSOM. Now that we discussed all the discharge points, very quickly let's recapitulate what are the differences between the mucosal and the squamosal disease, or rather the tuber-tympanic and the aticoantral type of CSOM when it comes to discharge. What are the various points that you will be noting over here? This is a very, very important Viva question. You will definitely be asked if you have gotten a case of CSOM. So there are 6 points under which we discuss. The first one is consistency. So consistency is in mucosal type is mucopurulent and sticky, whereas in aticoantral type it is purulent, thick and creamy. Coming to color, in tuber-tympanic it is whitish yellow in color because it is mucopurulent, and in aticoantral type it can be yellowish or greenish depending on which organisms have infected it. Coming to amount, it is profuse or copious in amount in tuber-tympanic type, whereas in aticoantral type it is scanty. Nature of the discharge is intermittent in tuber-tympanic and continuous in aticoantral. And foul smelling and blood-stained discharge is a feature of aticoantral and not a feature of tuber-tympanic. So these are the 6 various points that you will be using to differentiate the ear discharge between a tuber-tympanic and an aticoantral type of CSO. Next, let's move on to our second chief complaint, which is decreased hearing from the right ear. So, the first thing that we found out is that this reduced hearing is insidious in onset. Now, coming to onset of hearing loss, how will you be able to differentiate between certain causes? So, onset can either be an insidious one or a sudden one. So, insidious onset, some diseases where we see an insidious onset of hearing loss are CSOM, presbycusis, acoustic neuroma, otosclerosis, and noise-induced hearing loss. Whereas sudden onset of hearing loss is commonly seen in viral diseases, fractures of temporal bone, any kind of acoustic trauma, and vascular causes. Next point, also here we are seeing that there is a unilateral hearing loss. So it does not involve both the ears. So that again will help you in thinking of what are some diseases that causes unilateral hearing loss and what are some diseases that cause bilateral hearing loss. So unilateral hearing loss more commonly seen in CSOM, herpes zoster oticus, acoustic neuroma. Whereas bilateral hearing loss will be seen in presbycusis, Meniere's disease, otosclerosis, and noise-induced hearing loss. The next point is that in history we find that the patient is not able to hear whispered sounds. Now, a very important question here is, it is very easy for us to find out how much hearing loss a patient has once we perform an investigation, which is a pure tone audiometry. But if you do not have any access to that, if you are just taking history, how will you be able to perceive what is the degree of hearing loss that the patient is hearing? So, assess the degree of hearing loss from history. There are certain things you can ask the patient. Whether the patient is able to hear whispers, whether they are able to hear spoken speech, can they hear doorbell, can they hear loud sounds, are they able to hear when they are speaking on the telephone. So, these are all things which will give you a subjective view of how much hearing loss the patient possibly has. Next, the hearing loss is also not fluctuant. So that means there is a type of hearing loss that is fluctuating hearing loss. So what are some conditions where you see fluctuating hearing loss in? It is a very common condition seen in secretory otitis media, also known as glue ear. We can see it in Meniere's disease, perilymphatic fistula, and Lermoy's disease. These are some causes of fluctuating hearing loss. Patient has also mentioned that there is no change in hearing during discharge or absence of discharge. Now, why is this history important over here? Now, we'll see that sometimes patients who have a lot of discharge in the ear are actually saying that they hear better in the presence of discharge rather than absence of discharge. Now, that sounds kind of crazy. So, what is the phenomena that explains this? The phenomena that explains this thing is known as the round window baffling effect or round window shielding effect. So, let me explain this further. So, normally, what happens in a normal ear, the sound waves enter through the oval window via the stapes and they exit through the round window, and this allows the movement of perilymph, and then there is sound conduction happening. Now, in a case of CSOM, where we have a tympanic membrane perforation, here what happens is now the sound is able to reach the round window and the oval window directly. So, what it causes is it causes a phase cancellation. So, the sound windows are able to hit the oval and round window at the same time. So, basically, what we are seeing is a loss of phase differential over here. Now, this phase differential is very important to conduct the sound, to cause a normal conduction of sound. So, as there is a loss of phase differential, this leads to reduction in the hearing. Now imagine a case of a CSOM with tympanic membrane perforation, but there is discharge which is filling up the middle ear. Now, in this case, what is happening is the discharge can end up covering up the round window niche. So, this will prevent the sound which is entering the ear from directly hitting it. So, because now the sound is not directly hitting oval window and round window at the same time, we are maintaining a phase differential over here. And that is why the hearing will be temporarily improved even though there is a presence of discharge. So, this effect is known as round window baffling effect or round window shielding effect. That is the importance of taking this history. Last of all, we have also asked if the patient is able to understand speech or not. Now, why is knowing this important? This particular feature will help you in differentiating what to find out what is the type of hearing loss that the patient is experiencing. Is it a conductive hearing loss or is it a sensory neural hearing loss? Let me explain further what you will see in each of these. So, in a conductive hearing loss, the ability to comprehend speech or the ability to understand speech remains the same. There is basically just a block in the conductive pathway. So, if you raise your voice and you talk to the patient will actually be able to hear better. In contrast to this, in a sensory neural hearing loss, the ability to understand speech itself reduces. This is what it differentiates from the conductive hearing loss. So, in a patient with sensory neural hearing loss, especially if you are talking to a grandparents who have had age-related sensory neural hearing loss, even if you raise your voice and speak, the patient would be able to hear your voice, but they will still not be able to understand what you are trying to say. So, this is a very important history feature which will point towards what is the type of hearing loss that you get. So, this was all about the hearing loss perspective. So, in cholesteatoma, the first type of hearing loss that happens is usually a conductive type of hearing loss. But can we also see a sensory neural component sometimes? Yes, we can. And what would be the reason for sensory neural hearing loss in cholesteatoma? What can happen here is toxins can get released from an infection in cholesteatoma, and this can diffuse through the oval and round window and end up damaging the outer hair cells. In that case, this can lead to a sensory neural hearing loss component as well. Okay, now coming to negative history. Why have we taken all of these different negative history? What is the importance of it? Is it helping us rule out certain conditions over here? Let's discuss each one of them. First is ear pain. Now, in a case of CSOM, whenever a patient is complaining of ear pain, that should be a red flag sign to you that it is not an uncomplicated CSOM anymore. It is definitely pointing towards some kind of complication. So, ear pain will be seen in cases like mastoiditis, subperiosteal abscess, petrositis, and intracranial complications of CSOM, and if there is an associated otitis externa. A very important feature of otitis externa here is that in these cases you will get a tragal sign positive. When you press the tragus of the patient, you will see the patient wincing and pain, and that will point towards otitis externa. Next is giddiness. Whenever there is giddiness, it is more suggestive of two things. Either there has been a vestibular involvement, like cases like labyrinthitis or labyrinthine fistula, or there can be a cerebellar abscess. Now, if you're talking about labyrinthine fistula here, can you tell me what is the most common site for a labyrinthine fistula to develop? The most common site is the lateral semicircular canal. And even in the lateral semicircular canal, it is the ampullary portion of the lateral semicircular canal. Next, ringing sensation of the ear is usually indicative of some kind of inner ear involvement in the case. Next, we move on to fever. Now, when we're taking a history of fever, fever is more commonly seen in all these different complications of CSOM like acute mastoiditis, petrositis, lateral sinus thrombophlebitis, brain abscess. Headache. Headache is a feature of lateral sinus thrombophlebitis, brain abscess, subdural abscess, and extradural abscess. So, these are all the intracranial complications that we have to think of when we see headache. Nausea and vomiting will be seen in case of raised intracranial pressure, labyrinthitis, meningitis. Neck stiffness is a very, very typical feature of meningitis. There are different signs that you see for it, which is again outside of the scope of this discussion. Next, when we ask patient about changes in vision, are they having any double vision? Why do we ask that? Because this is a very, very typical feature of petrositis. So in petrositis, we see a syndrome which is known as Gradinigos syndrome. And one of the Gradinigos syndrome is basically a triad of features. And amongst this triad is the feature of diplopia. In this case, diplopia is happening because of the sixth cranial nerve palsy, which is the abducens nerve. Now, why does this abducens nerve get involved? Because abducens nerve runs very in close proximity to the petrous apex. Can you tell me the canal through which the abducens nerve runs close to the petrous apex? This is known as the Dorellos canal. Is the canal formed underneath the petroclinoid ligament. This is a entrance exam question that you usually get. And we'll also talk about Gradinigos syndrome in a little bit. What are the triad that you see in it? Next negative history is irritability. Irritability is a very common feature that you'll see in all the intracranial complications of CSOM. Next, facial asymmetry is seen. Again, facial nerve palsy is a feature of complication of CSOM. We take the history of trauma to rule out trauma as a cause of all the features that you are seeing. Any history of noise exposure and ototoxic drug will rule out as a cause of hearing loss. And nose and throat complaints will help you in finding out if there is any predisposing factors to the ear infection. Okay, so Gradinigo syndrome. As I said, Gradinigo syndrome is a syndrome that you see in cases of petrositis, and it involves a triad of symptoms. The first one being profuse otorrhea from the ear, retroorbital pain. This happens because of the trigeminal nerve involvement, and diplopia, which happens because of sixth nerve involvement. And why is fifth and sixth nerve getting involved? Because they both lie in close proximity to the petrous apex. Now we'll come on to discuss our past history. Now, in past history, we have asked about similar complaints in the past. This is important for you to know the chronicity of the disease. How long has it been present? Has there been any treatment given for it? And how has the patient responded to the treatment? Has there been any surgery done in the past? Next, we also ask about certain medical history. Let's talk about the importance of each one of them. First of all, diabetes mellitus. Now, in diabetes mellitus, the patients will more commonly have sensory neural hearing loss. They are more common to have malignant otitis externa and otomycosis. And also, the importance of knowing diabetes mellitus history is if we are planning to take up the patient for surgery, the sugar levels definitely have to be controlled before we take them up to the OT. Second, in hypertensive patients, more sensory neural hearing loss is seen. And again, the same point applies. If we are planning for surgery, the blood pressure levels have to be maintained before we take them up. Next, history of tuberculosis. We have seen something known as tuberculous otitis media. Now, there are very distinct features that you see in cases of TB involving the ear, and that is usually the patient will have painless otorrhea. There is no pain. This is a very characteristic feature. Painless otorrhea, which is not improving on medication, and it has multiple perforation. Again, this is the total MCQ that you'll get in your entrance exams. What is the condition where you get multiple perforations on the tympanic membrane? The middle ear mucosa will be pale, and hearing loss will be profound and disproportionate between the clinical findings and the Pearson audiometry findings. Next, a history of thyroid disorder. This is important because antithyroid drugs and hypothyroidism in both this has been seen to cause giddiness in patient. So in case of your patient is complaining of giddiness, this will also be one of your differentials at that point. Next is a history of exanthematous fever. Now, this is important from two perspectives. One is that whenever there's repeated, when there's exanthematous fever history, especially in children, it indicates more towards a poor immunity of the patient, and which leads to repeated upper respiratory tract infections. And that would be one of the etiology behind causing CSO. And second, when there's exanthematous fever in an early age group, like scarlet fever, for example, it has been seen to cause a disease which is quite rare, but which is known as acute necrotizing otitis media. So, this is why we should take the history of exanthematous fever as well. And last of all is bronchial asthma history. This is very important from pre-operative evaluation because usually a lot of these cases are taken up on general anesthesia, and this can lead to a complication during anesthesia because sometimes it can cause bronchospasm, and if the patient already has bronchial asthma, this may further exacerbate it. Now, what is the importance of taking addiction history? Now, addiction history is important because smoking hampers the mucosal clearance in chronic otitis media cases. And if you're taking these patients up for surgery, you have to explain to them that smoking has to be stopped 3 to 4 days prior to surgery for a better hearing outcome, better outcome of the surgery to happen. That is very, very important. Okay, now we have finished all of the history features. Now let's move on to discussing the clinical examination. So general and systemic examination is mostly normal. So I'm going to skip over directly to what we have found in the ear. So in the ear, left ear is normal, and in the right ear, we see pinna preauricular area and postauricular area are normal. We see purulent discharge in the external auditory canal. When we examine the tympanic membrane, we notice a attic perforation in the pars flaccida. Purulent discharge with cholesteatoma flakes are seen, and granulation tissue is also seen protruding through the perforation. And pars tensa, there is a grade 2 retraction. It is pearly white in color. Cone of light is absent, and we notice a partial scutum erosion. When we perform a tracheal tendinous, 3-point tendinous, and fistula test, they are all negative for both the ears. Coming to functional tests, in Rinne's test in the right ear, it is negative for 256 Hz, 512 Hz, and positive for 1024 Hz, whereas it is positive for all of the frequencies in left ear. Weber's is lateralized to the right ear, and absolute bone conduction test is same as examiner in both the ears. In balancing tests, we see a negative Romberg's test, gait is normal, nystagmus is absent, there is no past pointing or dysdiadochokinesia, and facial nerve examination is normal. And rest of all examination is also normal. Now let's start discussing each one of these clinical examination, starting from the ear. Now, a very important question, very basic question rather, I'll ask you is, which ear should we examine first? Should we see the normal ear or should we see the diseased ear? And why? So the answer to this is, first, you should definitely examine the normal ear of the patient. There are few reasons to it. First of all, on seeing the normal ear, you will first be able to see the normal anatomy first before you move on to pathology of the other side. Secondly, this will also help in preventing any transfer of infection from the diseased ear to the normal ear. And thirdly, this will also help you in gaining patients' confidence, because on the pathological side they may have pain. So on when you try to examine the patient, sometimes the patient ends up wincing in pain, so they might not let you see the other ear after that. So these are all the reasons why you should be examining the normal ear first. Okay, now the different parts that we have seen and what are we trying to see in each of these cases. So first, let's start with preauricular area. In preauricular area, we're trying to look for if there is any sinus, if there is any enlarged lymph node, any scar present or any skin tag present, if there is any other congenital deformity of the region. These are all things that you should be noting in the preauricular area. Next, coming to pinna, we'll see, look out for the normal architecture, if the size of the pinna is normal, what is the extent of the pinna, if there is any pathology like cauliflower ear, keloid, perichondritis. Now, when you're discussing about the normal size of the pinna, how do you know what is the normal size of the pinna? Is there a certain dimension you're supposed to check? Or is there some kind of surface landmark you have to check? So the size usually will vary from person to person, but normally it should extend from the supraorbital margin to the ala of the nose. Now there's a sign which is known as Frank's sign in relation to this area. And what is Frank's sign? Frank's sign is when you are able to see a diagonal crease in the earlobe which is running backwards from the tragus to the edge of the earlobe. You can see this is the tragus over here. You can see a diagonal line, which is diagonal crease, which is running in the earlobe, and it is running backwards from the tragus to the edge of the earlobe. This is known as Frank's sign. What is the importance of Frank's sign? Frank's sign is a possible marker for cardiovascular disease, especially coronary artery disease and atherosclerosis. The exact cause of this is not known, but it can reflect, maybe it is happening because of some microvascular changes or premature aging of elastic tissue, similar to what's seen in the vascular diseases. Next, moving on to the postauricular area. So in postauricular area, we see for any scars, especially if there has been a previous surgery, if there's any lymph nodes, what is the status of the retroauricular or the postauricular groove, if there's any sinus or fistula. So here is some examples of images. You can see the first image is that of a post-oral heel scar. So this is the post-oral approach to doing a tympanoplasty or a mastoidectomy. The second image over here shows the presence of a post-oral fistula. We were talking about the retroauricular groove. What is a condition where you see that the retroauricular groove has been obliterated? This is seen in cases of mastoid abscess. You can see in the image over here that the retroauricular groove has actually been obliterated, and the pinna is seen to be pushed downwards and outwards in this case. This is a very typical feature of mastoid abscess. Now, this brings up a very famous Viva question, which is, what are the differences between mastoiditis and a case of furunculosis? What are the clinical the clinical examination that you'll find in the patient? First of all, in terms of pinna position, in mastoiditis, the pinna is pushed downwards and outwards, whereas in furunculosis, it is pushed outwards and laterally. In mastoiditis, the postauricular groove is obliterated, and in furunculosis, the postauricular groove is accentuated. In mastoiditis, there is tenderness over the mastoid process and Simba concha, whereas in furunculosis, there is a tragal tenderness that we see. So the tenderness is in different areas. In mastoiditis, external auditory canal, you can see a posterior canal wall sagging, whereas in furunculosis, in EAC, you'll see a red tender furuncle. Tympanic membrane is usually normal in furunculosis and it can be bulged, inflamed, or perforated in case of mastoiditis. The mastoid will have a typical appearance which is known as ironed out mastoid in mastoiditis, which we'll discuss in just a little bit. And the mastoid will be normal in furunculosis. Hearing loss is usually conductive in mastoiditis. Furunculosis may not have a hearing loss, or if there is a hearing loss, it will be mild, conductive, and type. Mastoiditis will have fever and other systemic signs, whereas that is uncommon in case of furunculosis. So these are the differences in the clinical findings between mastoiditis and furunculosis. And this is a very famous Viva question that you get. Okay, next let's discuss about what are some signs that you know in relation to mastoid. There is 3 signs. One is ironed out mastoid, which we just discussed, battle sign, and Grissinger sign. Now let's look into each one of these signs. Which condition do we see it in, and how does it look like? So ironed out appearance of the mastoid is a very common feature of mastoiditis. If you see in the image over here, you can see how smooth the surface of the mastoid is looking like. Usually the mastoid surface when you touch is very bumpy. There's like a lot of ridges as if. But here you see a smooth ironed out appearance of the skin over the mastoid. This happens because there is a thickening of the periosteum, which happens because of the underlying periostitis. That leads to the formation of this ironed out appearance of mastoid. This is a very common feature that we see in cases of mastoiditis. Next is the battle sign. Now, battle sign is when you see the development of ecchymosis over the mastoid process. And this is usually seen in cases after trauma. And the most common fracture that is involved with it is the middle cranial fossa fracture. You can see the appearance of ecchymosis over the mastoid process over here. And what is the most common artery involved in middle cranial fossa? It is the middle meningeal artery. So that's about the battle sign. Next is Grissinger sign. A Grissinger sign refers to when there is a development of edema over the post-auricular soft tissue overlying the mastoid process. This usually happens as a result of thrombosis of the mastoid emissary veins. You can see there is some edema development happening over the post-auricular soft tissue here. And this is a typical feature of lateral sinus thrombophlebitis. This is a very important Viva question and even an entrance exam questions for you. Okay, let's move on to the next part. Next is what the findings that we have seen in the tympanic membrane. Now we have seen that there has been a grade 2 pars tensor retraction. So that will bring us to the question of what is the grading of pars tensor retraction. The grading is known as Said's classification, and this is a topic that I've already discussed in a separate video. You can check it out over there. There are 4 grades over here. The first grade is when there is a tympanic membrane is minimal retraction, but it does not contact incus. Grade 2 is when it is touching the long process of incus or stapes. Grade 3 is middle-ear atelectasis, where it is in contact with promontory, but it will still move on segalization. And grade 4 is an adhesive otitis media, where it is plastered to promontory and it does not move on segalization. If you want to know how to represent this in a schematic diagram, please check out my video on Said's classification. So what are some features that you see when there is a case of retracted tympanic membrane? What will you notice in the tympanic membrane? So first of all, the tympanic membrane will not be shiny anymore. It will look dull and lusterless. Cone of light will be absent. So cone of light is usually seen in the antero-inferior quadrant. If you see in the image over here, this is the antero-inferior quadrant. You can see that there is no cone of light. You will also be seeing the foreshortened handle of malleus. What does that mean? Foreshortened mean there is actually no real erosion of the malleus, but it appears to be as if it has been shortened. So you can see that the handle of malleus looks foreshortened over here. You'll also see prominent anterior and posterior malleolar folds. You will see that the lateral process of the malleus is very prominent. And last of all, is there will be restricted mobility of the tympanic membrane. So these are all the features of a retracted tympanic membrane that you should know when you're examining the patient. Next, as we are discussing about the retraction, we have discussed about pars tensa retraction. There is also pars flaccida retraction. And in our case, we have found stage 3, where we have seen that there is a partial erosion of scutum. Again, if you want to know TOS classification in details, I'll not be discussing over here because there's still a lot more to discuss. You can definitely check out my video where I've also shown how to draw schematic diagrams of each one of these stages. Okay, now that we are discussing about retraction, first thing we need to know is what is the most common place where the retraction pocket starts, and that is known as the Prusak space. That brings us to the next obvious question, which is what are the boundaries of Prusak space? You can see in the image over here, this is the Prusak space. You'll see that laterally it is bounded by the pars flaccida part of the tympanic membrane. Medially is the neck of the malleus. Superiorly, it is bounded by the fan-shaped lateral malleolar fold, and inferiorly, it is bounded by the lateral process of malleus. So these are the 4 boundaries of the Prusak space. This is a very, very, very important Viva question and even important from your practical perspective. Next, we examined for tragal tenderness, which I've already mentioned. Tragal tenderness is more indicative towards having the presence of otitis externa. Next, we did a 3-point tenderness test, which came to be negative for our case. Now, what is this 3-point tenderness test? How do you do it and what do you infer from it? So this is also known as a 3-finger test, where we usually use 3 fingers. So we place the index finger on the cymba conchae, middle finger over the posterior border of mastoid, and thumb over the mastoid tip. And no-brainer over here is you should not press all of them at the same time. Rather, you should press on each of these points alternatively. And then you notice which point has more tenderness in this patient. So when there is a tenderness over the cymba concha, it indicates tenderness over the antrum. That's because underneath the cymba concha lies the suprameatal triangle, which is also known as the McEwen's triangle. We'll discuss about this in a little bit. And underneath the McEwen's triangle lies the mastoid antrum. So cymba concha tenderness will point towards tenderness over the antrum. Tenderness over the posterior border of mastoid will indicate mastoiditis, and tenderness over the mastoid tip will indicate a mastoid emissary vein thrombosis. So this is the 3-finger test or 3-point tenderness test. Now, let's talk about McEwen's triangle and what is the importance of it. So first, let's find out what are the boundaries of McEwen's triangle. So superiorly, you can see with the red line over here, superiorly it is lined by the supramastoid crest or the temporal line. Anteriorly by the green line over here, which is a line along the posterior superior margin of the external auditory canal. And posteriorly, it is bounded by a line which is tangent joining these 2 lines. And this line bisects the supramastoid crest. So these are the boundaries of McEwen's triangle. Now, what is the importance of McEwen's triangle? We have just learned that the McEwen's triangle, deep to it, lies the mastoid antrum. And a very common Viva question that is asked to you is, how deep does the mastoid antrum go? So the mastoid antrum lies 1.5 centimeter deep to the McEwen's triangle. Next test that we did was the fistula test. Now, what is the fistula test? How do you do it? What instrument do you use to do it? And what are the different interpretation, the results and interpretation in this case? So first of all is the fistula test is done to detect the presence of fistula in the bony walls of labyrinth. What you do here is, first of all, it is very important to seat your patient. The patient should not be standing when this test is performed, because once you perform this test, if it comes out to be positive, the patient will be experiencing nystagmus, giddiness, vomiting, nausea, sensations. So you should explain the procedure to the patient first and make them to sit down. Then the air inside the EAC is compressed by 2 methods. Either you can do that by alternatively pressing the tragus, or you can use the Siegel's pneumatic speculum. This pressure is transmitted to the tympanic membrane, middle ear, and labyrinth. And if, in case there is a fistula present, you'll see that there is a nystagmus that is produced towards the disease site. This is how you perform the fistula test. Now, what is the instrument that is used? The Siegel's pneumatic speculum is used over here. Now, there are some few practical questions that you need to know in terms of Siegel's pneumatic speculum. We know that the Siegel's pneumatic speculum has oral speculum and then it has a lens. What type of lens is it? This lens is a biconvex lens, and the power of this lens is 10 diopters, and magnification is 2 times magnification. So these are some very important viva questions related to Siegel's speculum. And next, it brings up to what are the other uses of Siegel's speculum other than performing the fistula test. So it is because it can do 2x magnification, it is used to do magnified otoscopy. It can be used to check the mobility of tympanic membrane, perform fistula tests, deliver medications inside, used in wax or debris removal or otorrhea suctioning under magnified vision, or it can also be used to perform Kelly's test, which is one of the tuning fork tests that you use to do. Next, what are the different results you can see in a case of fistula test? We can see a positive fistula test, which will basically show the presence of some kind of fistula. Now, a positive fistula sign will be seen in labyrinthine fistula, fenestration operation, perilymphatic fistula, and post-epidectomy cases. Now, when do we see a negative fistula sign? Negative fistula sign is seen in cases of normal individuals and in cases of a dead labyrinth. Next, there is something which is known as Hennebert's sign. What is Hennebert's sign? So, Hennebert's sign is basically a false positive fistula test, which means when you are giving these pressure changes in the external auditory canal, this will cause vertigo, nystagmus, nausea, even in the absence of any actual fistula in the bony labyrinth. Hence, it is a false positive test. And the 3 important causes over here are, first of all, is congenital syphilis. This happens because of hypermobility of the stapes foot plate in these cases. Second is Meniere's disease, which happens because of a fibrous band connecting the utricle to macula. And third, it happens in cases of superior semicircular canal dehiscence. This is also an entrance exam question as well as an important viva question if you have mentioned fistula test in your case. This brings on also to the point that there is also something which is known as false negative fistula test. And what are the causes of that? So, false negative fistula test can be seen when there is a fistula, but yet the fistula test is coming out to be negative. This could be seen in cases of fistula which is covered by cholesteatoma or granulation or polyp. And this can also be seen in cases of dead labyrinth. So, this is all about the fistula test that you need to know. Next, let's discuss the functional tests that we have seen. So we have performed the Rennie's test over here. So the first question that I'll ask you over here is, how will you find out what is the grade of hearing loss from performing tuning fork tests? So this is found out by doing Rennie's test with different frequency of tuning fork. So we use 3 tuning forks, 256, 512 and 1024 Hertz. When we see that the Rennie test is negative with only 256 Hertz and positive for the other two, this indicates a mild conductive hearing loss of 15 to 30 decibel. When the Rennie's is negative with both 256 and 512 Hertz but positive for 1024, this indicates a moderate conductive hearing loss of 30 to 45 decibel. And when there's Rennie's negative for all of the 3 tuning forks, this indicates a severe conductive hearing loss of more than 45 decibel. So in our case today, we have found that the patient has a moderate conductive hearing loss. Next, a very practical question here would be, say you do not have all the 3 tuning forks with you. In that case, which frequency will you prefer most to use for your tuning fork tests and why? You will prefer using the 512 Hz tuning fork. Why? Because of 3 reasons. First of all, this lies within the speech frequencies. This tuning fork has less overtone and tone decay is very less in this tuning fork. So if you had only one tuning fork, you would prefer it to be a 512 Hz tuning fork. Now we are discussing Rini. Let's discuss one or two more questions in regards to Rini's test. First of all is, what is a false negative Rini? Now, false negative Rini test is when the result came out to be Rini negative, but it is actually not true for that case. And this is commonly seen in severe unilateral sensory neural hearing loss. Now we need to understand why do we see it over here. So in severe unilateral sensory neural hearing loss, the patient does not perceive any sound of tuning fork by air conduction, but they respond to bone conduction over here. Why? This bone conduction response that is happening is actually not from the diseased ear, but rather from the opposite normal ear via transcranial transmission of sound. That is the reason for bone conduction over here. And this phenomena is known as crossover phenomena. This is why you get a false negative Rini in a case of severe unilateral sensory neural hearing loss. Next, if you had to choose and perform only one test in between Rini's and Weber's, which one would you do? We will choose the Weber's test. And why? This is because Weber's test is actually a more sensitive test than Rini in detecting hearing loss. Because Weber's can actually detect hearing loss as minimum as 5 decibel. Whereas for Rini's test, a minimum hearing loss of 15 decibel is required to show any change in the results. So that is why if you had to choose only one test, you would be choosing the Weber's test. Okay, so that completes the section about the ear examination and what findings we have found. Next, in amongst all the other examination that we do, why is neck examination important in a case of ear? There are a few reasons to it. First of all, we know that as a complication of CSOM, there's multiple abscesses that can form as a result of it. So these abscesses can form in the neck area, like Bezold's abscess. So it is very important for us to know the different types of abscesses and which positions to check in the neck. Secondly, if there is a complication of lateral sinus thrombophlebitis, this will have some signs in the neck while you examine the internal jugular vein. Thirdly, any palpable lymph nodes in the neck in a case of temporal bone malignancy will upstage the disease and will act as a poor prognostic indicator of temporal bone carcinoma. So these are some reasons why neck examination is also important in a case of ear. You should not just look at the ear and come to your diagnosis and ignore all the other parts. Okay, now let's summarize the case. So, a 35-year-old male has presented with the chief complaint of discharge from the right ear for 2 years and diminished hearing in the right ear for 1 year. Discharge is insidious in onset, continuous, scanty, purulent, yellow, foul smelling, blood-stained, and relieved by medication. Diminished hearing in right ear is insidious in onset, gradually progressive in nature, not able to hear whispered sounds, non fluctuant, no change in hearing during discharge or absence of discharge, able to understand speech. On examination of the right ear, we see an attic perforation, a purulent discharge with cholesteatoma flakes are seen, granulation tissue seen protruding through the perforation. We see a grade 2 retraction of pars tensa, cone of light absent, and partial scutum erosion is seen. Tuning fork test revealed negative Rini for 256 and 512 Hz and positive Rini for 1012 Hz. Weber's is lateralized to right side and ABC test is same as examiner. So that is our summary of the case. Now, that brings us to the question, what is our provisional diagnosis over here? So, our provisional diagnosis here is right-sided active squamosal type of chronic otitis media with moderate conductive hearing loss without any complications. So, all of these words that I have just mentioned is very important. You can't just say like, hey, this is an adipoantral CSOM. That will be an incomplete provisional diagnosis. So, what are the things that you have to mention? First, you'll mention which side is it. Second, the stage of the disease, active or inactive. Third is the type of the disease, whether it is a mucosal type or a squamosal type of chronic otitis media. Fourth, what is the hearing loss that you are seeing over here? Is it a mild, moderate, or severe hearing loss? Is it a conductive, sensory neural, or mixed hearing loss? And fifth, is there any presence of complications or not? So there are all these different points that you have to mention in the provisional diagnosis. Now that we have come to a provisional diagnosis, the next question that will come to you is, why do you say this is your provisional diagnosis? Can you tell me the points in favor of your diagnosis? So, first of all, from history, we have seen that the ear discharge has certain features like it is scanty, yellow, purulent, foul smelling, blood stained. This is all indicating towards our aticoantral type. So, aticoantral, I'm using the term only because it's a more common term that we all know, but the recent nomenclature tells us to use squamosal type of CSOM in replacement of the aticoantral type. So we have seen that these all features of the ear discharge is pointing more towards the aticoantral CSOM. And in examination, we have already seen an attic perforation, we have seen cholesteatoma flakes, granulation tissue, and partial scutal erosion, which is again all in line with aticoantral CSOM. Next, we have seen that the patient has a conductive hearing loss, and this we have deduced from the fact that RINI is negative for 256, 512 and positive for 1024. So this has indicated not only has a conductive hearing loss, but that the conductive hearing loss is moderate. And next, we have seen that there was no other history of fever, nausea, neck rigidity, changes in vision, all those other negative history that we have taken. So this rules out any kind of complications that could happen. So this is how these are all the points that are in favor of the provisional diagnosis that we have formed. Okay, now let's discuss a few Viva questions that you will be asked in relation to all of this. First of all, we've seen that we have seen the presence of a granulation tissue. What is a granulation tissue? If you see in the image over here, this is the granulation tissue that we are seeing here. So, granulation tissue is basically a vascularized fibrous tissue over an underlying osteitis. So, whenever you see a granulation tissue, it is indicative of the presence of an underlying osteitis. It is usually bright red, soft, and bleeds easily on touch. Next question. Now, what is chronic suppurative otitis media? So, chronic suppurative otitis media is defined as chronic inflammation of the mucoperiosteal lining of a part or whole of the middle ear cleft, characterized by ear discharge and permanent perforation of the tympanic membrane. A middle ear cleft involves the eustachian tube, attic, middle ear, adytus, antrum, and mastoid air cells. I have already made a video on chronic suppurative otitis media. You can check out for more details over there. Now, what are the different types of CSOM? So earlier, according to the earlier nomenclature, we used to divide it into tubotympanic, which is a safe type, and aticoantral or the unsafe type. But the current nomenclature divides it into mucosal disease and squamosal disease. Mucosal is basically equivalent of the tubotympanic type, and aticoantral type is equivalent of squamosal disease. So in mucosal disease, it involves the anteroinferior part of the middle ear cleft, which is the eustachian tube and mesotympana. So, mucosal disease in itself can be divided into three types: active, inactive, and healed. If you see in the first image over here, this is the active type where we see the presence of a permanent defect of the pars tensa in the form of a perforation. And you also see that there is an inflamed middle ear mucosa which is producing mucopus that may discharge. Second is the inactive type. The second image over here, you can see this is a case of inactive mucosal COM where we see a permanent perforation of pars tensa, but on examination you see that the middle ear mucosa is not inflamed. And third is a case of healed mucosal disease, which can be two types. One, and when it's in the third image over here, you can see that there is a thinning and local or generalized opacification of the pars tensa without perforation or retraction. So you can see that there is no perforation over here, but this is also not a normal tympanic membrane. Or you can see the presence of tympanosclerotic plaques. So these are the two types of heel otitis media that you can see. Next is a squamosal type of disease, also the atticoantral type, which involves the posterior superior part of the middle ear cleft, which is the attic antrum posterior tympanum mastoid. So, squamosal disease in itself can be divided into two parts, inactive and active. Inactive is when we see a retraction pocket. So, in the first image, you can see that there is a presence of a retraction pocket in the attic. So, inactive type is when you see either a retraction of pars tensa in the posterior superior part or in the pars flaccida, which has the potential to become active with retained debris. And the second type is the active type, which is the presence of cholesteatoma, where we see a retraction of pars tensa or flaccida, which has retained squamous epithelial debris and is associated with inflammation and production of pus. So, this is the classification of chronic otitis media. That brings us to the question. Our case is a case of atticoantral disease where we have seen the presence of cholesteatoma. So, what is a cholesteatoma? Cholesteatoma is defined as a benign sac of keratinizing squamous epithelium in the middle ear cleft with bone eroding property, which has also lost its self cleaning capacity. I have made a separate video on cholesteatoma already. To know more about it, about the theories, about the different types. You should definitely check my video out. So, next, that brings us to the theories of cholesteatoma. Again, this is not something I'll discuss over here. You can check out my video. But the different theories are the invagination theory, basal cell hyperplasia theory, epithelial invasion theory, and Say's metaplasia theory. This is a very common Viva question that you will get when you get a case of cholesteatoma. Now, how does cholesteatoma erode bone? There are three methods to it. One is the pressure necrosis theory, which is today outdated. This was the first reason thought to be the reason for bone destruction, but the theory was abandoned because it was unlikely that cholesteatoma can exert pressure which exceeds the capillary perfusion pressure, which is approximately 25 mmHg. Second, the most accepted theory is the enzymatic theory, where basically enzymes are liberated by osteoclast and mononuclear inflammatory cells. And these enzymes include collagenase, acid protease, acid phosphatase, cathepsin like proteolytic enzymes, PGE2, interleukin 1 alpha, interleukin 1 beta, TNF alpha, TNF beta, etc. And the third way to erode bone is through hyperemic decalcification. So these are the three mechanisms as to how the cholesteatoma erodes bone. Next, talking about bone erosion, which is the first bone to get eroded in cholesteatoma and why? It is the lenticular process of the long process of incus. Why? Because this area it possesses is only a single nutrient vessel and it lacks any kind of collateral circulation. That is why it is very easy for it to undergo erosion when this blood supply gets interrupted. Next, let's talk about a little about the spread of cholesteatoma. Again, please check out my video for more details, but I'll just in short, cholesteatoma originates from three sites. And the three sites are the most common, first being posterior mesotympanum, which is this area. So posterior mesotympanum is the most common site of origin of cholesteatoma, which is basically in the Prusac space. Second type is when it develops in the posterior mesotympanum. And the third type when it develops in the anterior epitympanum. So these are the three sites of origin for cholesteatoma, and accordingly, each of these sites have different pathways of spread. So in our case, let's discuss the most common one, which is the Prusac space or the posterior epitympanum cholesteatoma. So this cholesteatoma usually starts in the Prusac space. Then it has different methods of spread. First, through the posterior pouch of von Trolsch, it can spread into the posterior mesotympanum and hence end up going to sinus tympani and facial recess. Second, through the anterior pouch of von Trolsch, it can go into anterior epitympanum, then to the supratubal recess and anterior epitympanic sinus. Third, through the lateral malleolar folds and lateral incudal folds, it can go into the superior incudal space, and from there it can go to the adytus, antrum, and then involve the mastoid. So these are the three different spreads of posterior epitympanic cholesteatoma. Next, we just spoke about the anterior and posterior pouches of von Trolsch. Can you tell me the boundaries of them? This is again a Viva question that you'll be asked. So the anterior pouch of von Trolsch is a blind pouch. If you see in the image, the green portion over here is the anterior pouch of von Trolsch. It is bounded medially by the anterior malleolar fold and bounded laterally by the tympanic membrane. And the posterior pouch of von Trolsch, which is shown by the blue shaded region over here, it is bounded medially by the posterior malleolar fold and laterally by the tympanic membrane. Next, let's discuss a scenario here. So there are two cases. One is when there is a complete ossicular discontinuity but with an intact tympanic membrane. And second is the case of ossicular discontinuity with a perforated tympanic membrane. Now, which of these cases will have a higher hearing loss and why? Now, funnily, it's not actually as intuitive as you'd think. It's actually not a case of perforated tympanic membrane. In fact, an intact tympanic membrane and complete ossicular discontinuity, we see a higher hearing loss. And why is that? This is because in ossicular discontinuity, if the tympanic membrane is intact, so when the sound reaches the tympanic membrane, it will vibrate the tympanic membrane. But because there is no ossicular continuity, the broken chain will not be able to send the sound to the inner ear. Whereas, same case, an ossicular discontinuity, but now there is a perforation in tympanic membrane. So now the sound waves will be able to enter the middle ear, which it was not able to do in the case of an intact tympanic membrane. So it will enter the middle ear and it will stimulate the oval and the round window directly. Therefore, we'll end up seeing a more hearing loss in case of an intact tympanic membrane. So in intact tympanic membrane with ossicular discontinuity, we see a hearing loss of 55 to 60 decibel, and that with a perforated TM, we see a loss of 45 to 50 decibel. Next, there's a condition which is known as cholesteatoma hearer. What does that mean? So cholesteatoma usually leads to ossicular erosion, but sometimes this will not cause a lot of hearing loss here. Why? In some people, what happens is the ossicular discontinuity that has been caused by erosion, this is bridged by the cholesteatoma in between the ossicles. So it kind of acts as if the ossicles are still there even though it is not there, and this leads to better hearing. So these patients are known as cholesteatoma hearer, where you have a better hearing compared to other normal cholesteatoma cases. Now, what is the minimum hearing loss that you will suspect, that you need to see to suspect a case of ossicular discontinuity? An airborne gap of more than equal to 30 decibel on a pure tone audiometry is strongly suggestive of ossicular discontinuity. Why is it 30 decibel? That's because ossicular chain discontinuity causes a significant conductive block to sound transmission. So an airborne gap which is less than 20 to 25 decibel will be more suggestive of a severe middle ear pathology like middle ear effusion, etc. However, large gaps like more than 30 decibel with an intact TM should definitely raise the suspicion of ossicular discontinuity in the patient. Okay, so these have been some Viva questions in relation to this. Now let's discuss how are we going to manage the case. As I've repeatedly mentioned in all my other case discussions, that management will always comprise of investigation and treatment. It is not only treatment. So first, let's talk about the investigations. First of all, we'll do some general investigations like take the surgical profile of the patient. We have already discussed in previous case discussions about surgical profile, what are the tests you should do and why should you do them. I'll move on to the others now. In specific examination, first of all, you should do an examination under microscope under local anesthesia. The purpose of this is to first confirm your otoscopic findings. Second, to check for ossicular chain status in cutostepidial joint, middle ear mucosa, and to do suction clearance if discharge is present. Second investigation is we'll do a pus for culture sensitivity. If in case there is pus, we can start our patient first on broad spectrum antibiotics, but if we find any pus, we can send for culture sensitivity and change into relevant antibiotics if it is needed later. Next investigation is a pure tone audiometry. Now, why do we do a pure tone audiometry? First of all, we need to know the type of hearing loss. Is it conductive? Is it sensory neural? Or is it mixed? Then we need to know the degree of hearing loss. Third, it is important for documentation for medico-legal purposes. And fourth, to compare the pre-op and post-op audiogram and see if there has been any hearing outcome improvement. And the last one is a HRCT of the temporal bone. Why is this important? We should do this to check the extent of the disease, to check for any anatomical aberrations, to check for any bone erosion, ossicular chain status, facial nerve dehiscence, etc. To see if there is any low-lying dura or anteriorly placed sigmoid sinus. This will help you in better prepare for the surgery, and to check for any impending complications. Now, we usually do only a HRCT of the temporal bone. Contrast enhanced CT of the temporal bone is indicated only in cases of intracranial complications of CSOM. Now, what is the role of MRI in case of squamosal CSOM? MRI is done only when you are suspecting intracranial complications of the disease, if there is a detection of residual or recurrent cholesteatoma. Also, to evaluate the inner ear and, for example, labyrinthine involvement and facial nerve involvement. So, these are the cases where you think of performing an MRI. Next, when we do a pus for culture sensitivity, what are the common microorganisms that you'll isolate in these cases? So, they're usually aerobic ones like Pseudomonas, Proteus, E. coli, Klebsiella, and anaerobic one could be Bacteroides. Now let's discuss how will you treat this patient. So I'll do a modified radical mastoidectomy under general anesthesia of the right ear. So that will take us into the mastoidectomy territory, and I'll discuss a few questions in related to that. So what is a modified radical mastoidectomy? This is an operation to eradicate disease from attic and mastoid, which are exteriorized into the external auditory canal by removal of posterior meatal wall and the lateral attic wall. How is it different from radical mastoidectomy? Here, the tympanic membrane remnant, functioning ossicles, and the eustachian tube function is preserved. Whereas in radical mastoidectomy, you obliterate all of this. You remove all the tympanic membrane remnant, functional ossicles, and you obliterate the eustachian tube opening. So this is what is modified radical mastoidectomy. Before we go into the steps and indications of modified radical mastoidectomy, what are some approaches to ear surgery? What are some incisions that you take? So there's the Rosen's endomeatal incision, Lempert's oral incision, and Weil's post-oral incision. I have a separate video where I have spoken about the incisions in ear surgery, so you can check more details out over there. That brings us to our next question. What are the indications of MRM? First obvious indication is the presence of cholesteatoma. It can also be done in cases of approaching the facial nerve for facial nerve decompression. Also in cases of chronic otitis media of the mucosal type, but with the presence of complications. And it is also done in cases of recurrent or residual cholesteatoma. Now, before we discuss the steps, what is the aim of our surgery over here? The most important aim over here is to first eradicate the disease and make the ear safe. And then our second aim will be to restore the hearing mechanism. So these are the two aims of our surgery. Now I'll discuss the steps of MRM in very short detail. I'll definitely make a separate video on this later. So first you give a postauricular incision followed by a periosteal flap elevation. Identify McEwen's triangle. Identify and remove all accessible air cells. Expose the mastoid antrum, sigmoid sinus, dural plate, sinodural angle. Perform saucerization, which means basically widen and smoothen out the mastoid cavity. Remove all the diseased air cells. Lower the posterior canal wall. This is done to connect the external auditory canal with mastoid cavity. Remove the facial bridge and lower the facial ridge. Exenterate all of the disease from all of the areas. Preserve ossicles if it is possible. Then we perform a meatoplasty where you widen the external auditory canal for post-op cavity access. Reposition the skin flaps to ensure adequate cavity ventilation. Irrigate the cavity with saline, line it with temporalis fascia or gel foam. Pack the cavity and ESC lightly and then perform a periosteal flap closure and suture up the incision and then apply a mastoid dressing. So these are in short the steps of MRM. Now, after you perform MRM, what we also have to think about our second aim, which is to restore the hearing mechanism. For that, we have to perform an ossicular reconstruction. Now, ossicular reconstruction can be done in two stages. Either it can either be a primary reconstruction or a secondary. Primary is when you do along with the MRM, you perform the ossicular reconstruction in the same setting, whereas secondary is done at a later stage after a period of 3 to 6 months of the first surgery. This is decided on a variety of factors, like if you think the patient will have a better outcome if you perform in two different sessions, if you think the patient will be compliant and actually come back for the second surgery or not. So these are all things you need to consider before taking that decision. So the most commonly we see that the incus is usually eroded. In this cases, the different methods of doing this ossicular reconstruction would be: first is you could do place an autologous cartilage on the stapes head. Second is you can do a partial ossicular replacement prosthesis. Third is a meningoplatinopexy, which is a type of ossiculoplasty procedure where tympanic membrane or graft is placed directly on the stapes footplate. So this is not something I'll go into details right now. I'll definitely make a video separately later about this. There's also a reconstruction of the posterior canal wall. If you do perform it, what are the materials that you use to perform a reconstruction of posterior canal wall? This can be divided into two: autologous material and alloplastic material. Autologous material are the material which you take from the patient itself. These could be cortical bone chips. These are the most commonly used one, which you harvest from the mastoid cortex. You can use a conchal cartilage, tragal cartilage, septal cartilage even. Alloplastic materials are basically synthetic or processed material, and you can use hydroxyapatite, titanium mesh, porous polyethylene. So these are all the things you can use to reconstruct the posterior canal wall. Now let's discuss a little bit about what are the disadvantages of modified radical mastoidectomy. First of all, you end up with a large mastoid cavity. So that opens up to cavity problems, which requires regular cleaning and care. Then there can be chronic discharge because of exposed mucosa and cavity. It can lead to altered ear anatomy. So you're basically ending up changing the natural ear canal anatomy. That can also lead to possible water intolerance and discomfort. The patient will also require lifelong follow-up to prevent any kind of infection or debris accumulation. It can lead to cosmetic issues because larger meatoplasty can alter the external ear appearance. Next, ear protection would be required. So patient would be cautious about avoiding water exposure to prevent any infections in the cavity. And if you want to give hearing aid to the patient, it becomes difficult because of the altered anatomy. So these are some of the disadvantages of performing an MRM. That brings us to the next question. What are the complications of mastoidectomy? You can divide it into two: intraoperative and post-op complications. Intraoperatively, the most common one is bleeding, then injury to a lot of different structures. So there can be injury to the facial nerve. The most common part involved is the vertical part and the second genu. Injury to the lateral semicircular canal, which can cause vertigo, sensory neural hearing loss. Injury to tegmen leading to CSF leak, dural exposure, or brain herniation. Injury to lateral sinus causing a torrential bleed and risk of sinus thrombosis. Injury to sigmoid sinus, which can lead to hemorrhage or air embolism. Injury to stapedius muscle leading to hyperacusis. Injury to chorda tympani nerve leading to taste disturbance. And we can also lead to ossicular chain damage. These are the intraoperative complications. Next are the postoperative complications, which can be wound infection because of delayed healing or persistent ear discharge. We can have a persistent ear discharge because of incomplete disease clearance or a secondary infection, a delayed facial nerve palsy, vertigo, which can be due to labyrinth irritation, hematoma or seroma in the postauricular region, CSF leak, graft failure, recurrent cholesteatoma when there has been incomplete removal or retraction pocket formation. Patient will have cavity problems. A very rare complication, but a very serious one, would be dead ear, where a total sensory neural hearing loss due to labyrinthine trauma or infections happen in the inner ear. Last of all, there can be a canal stenosis, which is a narrowing of the ESC. So these are all the complications that you can see in a case of mastoidectomy. Now, there are some terms, definitions that you need to know in relation to mastoidectomy. First of all is facial bridge. Facial bridge is that part of the posterior bony canal wall that overlies the fossa incudis. Facial ridge is posterior bony canal wall, which is covering the vertical segment of the facial nerve. Anterior buttress is the bone where the posterior bony canal meets the tegmen, whereas posterior buttress is the bone where the posterior bony canal and the floor of ESC meets, and this lies lateral to the facial nerve. And cog. What is cog? Cog is a coronally oriented bony septum which projects from the tegmen to the head of the malleus. And this separates the anterior epitympanic recess from the posterior attic space. So these are some common definitions of structures that you need to know in relation to mastoidectomy. And these are very, very, very important viva questions that you will 100% get if you are discussing about mastoidectomy. Next is cornus septum. Now, what is cornus septum? Cornus septum is basically this embryological junction between petrosal and squamosal part of the temporal bone. So, embryologically, this is a remnant of the petrosquamous septum, and this separates the superficial air cells from the deeper ones. Now, the importance of this is that sometimes you can reach the cornus septum and you may think that you have reached the antrum, but you may not have actually reached the antrum because of the presence of the cornus septum. You can see in the image over here, the antrum lies further deep. So, cornus septum can actually give you the false impression that you have reached the antrum. Next, we have been talking about mastoid cavity formation after performing MRM. So, what is the differential diagnosis for a large mastoid cavity? This is again another important viva question that you should know about. So, some common ones are erosion by cholesteatoma in a case of post-mastoidectomy cavity, megaantrum, which is a normal physiological variant, tuberculous mastoiditis, coalescent mastoiditis, malignancy, eosinophilic granuloma, and large emissary vein. These are the differential diagnosis for a large mastoid cavity. Now, the two common ones over here, how will you differentiate between them? In the case of a large mastoid cavity where it is formed by cholesteatoma, you'll see that this mastoid cavity will have irregular ragged edges, whereas a post-mastoidectomy cavity will be more smoothened out. That is how you will be able to differentiate between both. So the modified radical mastoidectomy is basically a canal wall down procedure that we perform. So there are other procedures which are canal wall up procedures, which are more preferable to be done. Why so? What are the advantages of performing canal wall up procedures? So with canal wall up procedure, you get to preserve the normal anatomy. These cases also have better hearing outcomes. They do not have any open cavity problems as we are facing in MRM. Cosmetically superior, more water tolerance, and these patients are also better candidates for hearing aids. Just a random question. There's a lot of canal wall up procedures that you should know about. Please read them out separately, and I'll try to make a video separately on canal wall up and canal wall down procedures as well. But what is combined approach tympanoplasty? This is a combination of anterior tympanotomy, posterior tympanotomy, and cortical mastoidectomy. What is the other names of cortical mastoidectomy? It is also known as simple mastoidectomy. It is also known as Schwartz operation. Next, what are the indications? We've discussed about the surgical part of management. So is there a way to do medical management for cholesteatoma cases? Well, that is definitely not the preferred approach. But there are certain indications in which you can do medical management in cholesteatoma. These are when the patient is unfit for surgery, if the patient is refusing surgery, if general condition of the patient is poor, and in case of very elderly patients. Now, how will you perform medical management in these cases? You can perform a repeated suction clearance of the ear, send the pus for culture sensitivity, give topical antibiotic eardrops along with steroids, and do repeated follow-up of the patient. Giving you some hypothetical cases here. If the patient has a near normal hearing but has an attic cholesteatoma, in that case, what should you do? In that case, you will be performing something known as atticoantrostomy, also known as Bondi's mastoidectomy. And if the cholesteatoma is extensively involving the antrum and the middle ear cavity, in that case, you should be doing a modified radical mastoidectomy. Next, what is recidivism? Now, the term recidivism itself, it means the tendency to relapse or return to a previous condition, behavior, or disease after an apparent recovery or correction. So, in relation to cholesteatoma over here, recidivism means the reappearance of cholesteatoma after a surgery. It can either be due to residual disease or a new formation, which is a recurrent disease. So, recidivism in cholesteatoma is of two types. Residual cholesteatoma, when cholesteatoma has been left behind unintentionally during initial surgery in hidden areas, and recurrent cholesteatoma, when a new cholesteatoma formation due to retraction pocket reformation, poor eustachian tube function, or a graft failure happens. So, this is recidivism in cholesteatoma. Now, I just mentioned about hidden areas because of which residual cholesteatoma can happen. Now, let's know what are the different hidden areas in the ear. Some of them are sinus tympani, facial recess, anterior epitympanic recess, supratubal recess, Prusac space, posterior tympanum, round window niche, sinodural angle, footplate of stapes, horizontal part of the facial nerve. These are some hidden areas in the ear where you can find residual cholesteatoma. That brings us to our last part almost, to sinus tympani and facial recess. It is very important that you know what are the boundaries of this. This is a very common Viva question and it's also important from your surgical perspective. So facial recess, if you see in the image over here, this is the facial recess and this is the sinus tympani. So facial recess is bounded laterally by the chorda tympani, medially by the vertical parts of facial nerve, superiorly by the fossa incudis, whereas sinus tympani is bounded bilaterally by pyramidal eminence of the facial nerve, medially by the posterior semicircular canal, superiorly by the ponticulus, and inferiorly by the subiculum. These are the boundaries of sinus tympani. Last question for today is, how do you differentiate between the different types of sinus tympani? So there are three types over here. Type A is when there is a shallow sinus and it does not extend medial to facial nerve. In this case, it is easily accessible during surgery. Type B is when it is of moderate depth and it extends medial to facial nerve. In this case, surgery, it is partially hidden, so it will require careful dissection. And type C is when there is a deep sinus tympani and it extends medial and posterior to facial nerve. This type is very difficult to access, and this possesses the highest risk of residual cholesteatoma formation. So these are all in relation to atticoantral disease case that I have discussed. Obviously, there's a lot of other questions that can still be asked. And if you have any query, any question you want to ask in relation to this, please note them down in the comment section and I'll get back to you. Thank you.